നമ്മുടെ ക്ലാസ് IMLA വെന്റിലേറ്ററിനെ കുറിച്ചാണ്. So primarily we will be talking about few things which will be useful to you for your exam. So um, first we will see what is oxygen therapy. How is oxygen therapy going to help us? So you all have gone through this when you are in the COVID time. So COVID has brought you a significant idea about oxygen. So COVID was essentially the primary aim where majority of the doctors has entered into oxygen. Now we should also know that essentially we are targeting an SpO2 of 93 percentage and SpO2 of 93 percentage and up to 95, which is considered to be normal for a patient breathing on room air. Now, anytime when it falls below, that, we always supplement the patient with oxygen. And this oxygen is not considered a drug until COVID. It was actually COVID which give us an idea that oxygen is a drug and not to be given to any person who come to casualty. So for that, we should know now that oxygen drug can be administered by two methods. Number one, it can be delivered through a low flow device, or you call it as variable performance device. Variable performance defines essentially means the amount of FiO2, that means the amount of oxygen that the patient gets depends on the patient's effort, and not on any oxygen delivery equipment. But at the same time, we do have another method called fixed performance device. This fixed performance device give you a fixed amount of FiO2 irrespective of patient effort. So here patient effort is not a concern for us. So this is a very common area where you get questions. So please understand that an example of a variable performance device is your nasal cannula and Hudson mask. Very common question. It has been repeatedly asked. While fixed performance devices, we have few examples to learn. Number one is it's essentially Venturi mask. Number two is breathing circuit. Number three is NRBM, non-rebreathable mask with a reservoir bag. So these are very common questions which are usually asked for your exam. Now we will see one by one. Please see this. This is a nasal cannula, very commonly asked question. Nasal cannula, it is very comfortable for the patient. So essentially it is a comfort. With this you can eat, drink and talk. Communication is possible. But the side effect is that if you go beyond 6 liters of flow, oxygen flow, it causes drying of the mucosa and can cause injury. The same problem is it cannot supply an FiO2 of more than 44 percentage. It's a very common question. Please note, The maximum FiO2 that a nasal cannula can provide is 0.44 at a flow of 6 liter of per minute of oxygen. So this is a very common question. Please remember this. Now, the minimum flow which you should keep is 2 liters. That is also an important question. Coming to the next one, this is what is known as Hudson's mask. Hudson's mask or non-rebreathing mask. But commonly, it is the question is this: they ask you to identify this mask and ask to identify the name. Please remember, this is an example of a variable performance device. There are a few more questions which you should know, that the dead space of this mask is 250 ml. And again, 2 liter is the minimum flow, and you can give a maximum percentage of 55%. Okay, so these are all very questions. Now, do remember that the side effect of this is claustrophobia. Patient feel that he is enclosed in a closed space and he cannot eat, drink, and communicate. Now, whatever we have discussed now, that the nasal cannula and the Hudson mask both are examples of variable performance device. So please remember that. And another disadvantage of both this is that it is not possible to provide a humidified air through both this device. Now coming to the third one, which is probably the most important, no MCQ setter fix a question on oxygen without a question on this one. This is Venturi mask. That is the importance of Venturi mask. If you go to any MCQ book or any exam, you would have noticed that Venturi mask is commonly seen. The commonest question is, what is the highest FiO2 that can be provided? It is 60%. And this is an example of a fixed oxygen delivery device. Number 3, it works on the principle of Venturi principle. Venturi principle essentially states that when gas flow at a very high rate, it actually brings down the pressure at its surroundings and entrail air from outside, providing a larger flow at the outlet. Okay, so this provide the peak flow. This provide the peak flow required for the patient. Next one. This is the last year INICT and NEET question. What is this? Identify this. You know this is a Hudson mask onto which you have attached a reservoir bag. We have a few charts here. Yeah, very good. It's an RBM. You don't call it as high flow mask. We call it as NRBM. Non-rebreathing mask. That's the correct answer. Non-rebreathing mask with reservoir. Okay. Non-rebreathing mask with reservoir is a classic example of fixed oxygen delivery device. The advantage is that if you have one-way valve, it can give you 80% of oxygen, and if you have two, If you have two one-way valves, it can give a maximum of 95%. Some books even say up to 98% of FiO2. So this is a very common question. Please remember this. So you have the commonest question they ask is, what is the highest percentage of NRBM with reservoir? And they ask you to identify the photograph. Okay, that's it. Now this was last year, no, 2 years back. That was probably 2021 question. What is this? This is HFNO. HFNO. Now, what is HFNO? During COVID time, we have seen HFNO. Many of us have not seen HFNO till then, but COVID has shown us HFNO. It is high flow nasal cannula. You keep the patient's head here, and through the nose, high flow oxygen is delivered to the patient. Okay. What is its use? Very good. Dr. Joseph has mentioned it rightly. Correct. So its use is, it helps us. Oh, sorry. It helps us to bridge the gap between falling trend in oxygenation and this patient going to ventilator. So essentially, it helps us to bring the patient from the gateway of the ventilator. It has saved a lot of people. The advantage is that it gives around 70 liters per minute of oxygen, such a high flow. What are the other advantages? The other advantage is that it provides humidified oxygen. It also provides high flow. Number three, it also provides high concentration. Number four, it provides positive end expiratory pressure. That means it reduces the work of breathing. All these are questions for you. Now, to identify a few of them, please note, this is the cannula, you call it as nasal cannula, of the HFNO. This is the flow meter, which shows how much oxygen is flowing depending upon the ball which moves up and down. You can see here, this is the warmer and humidifier. So these are all questions. Now, if the patient cannot be oxygenated by this, we will now go to ventilator. Yeah, high PEEP, that's right. Can I repeat fourth point? Dr. Danya Shri. Okay, Dr. Danya, it is positive end expiratory pressure. Now, once you have made the decision, I'm looking at the, okay, fine. Is there any doubt up to this? If you have any doubts, we can put it in the chat, and now we will go to the ventilator. Yeah, Dr. Reshni, what's your doubt on Venturi? Yeah, Venturi principle. Yeah, it's called Venturi principle. Venturi principle is nothing but air goes through a small nozzle. When there is increased velocity, the pressure falls around that, which entrails air from outside, making the flow to a larger extent. This is what is Venturi principle. It is also used in many conditions like nebulizer, suction device, etc. I hope the point is clear. Okay, I'll put off the video. The echo is quite high to me. It's quite disturbing. That's why I'm shorting in. I mean, I'm talking in a very low pace so that I can manage with my echo. I'm sorry for that. I think there is an issue with the network. Maybe the network is a bit slow. Okay, we will now go to ventilator. Please see, when is the first time when you want to put a patient on ventilator? The answer is very simple. When you think first that this patient may need a ventilator, that's the best time. So essentially, what I wanted to tell you is the first thought is the best time. Okay. Yeah. Dr. Joseph, what is your question about ABG? ABG that we can intubate. Initiate. Okay. Okay. That's a very according to the worsening ABG. Yeah. I got your point. So what Dr. Joseph want to know is what are the objective? Sorry. What are the objective finding? This is probably the gut feeling. Now he wants to know what is the objective way when you think this patient needs to be intubated. From a practical sense, I would say when the ABG suggests acidosis or when you think the patient's respiratory is very high, say for an adult male 35 and more, where the patient may not sustain, or he is gradually losing consciousness because he cannot protect his airway. And of course, whenever the ABG is worsening. So these are all objective ways to put the patient on ventilator or to support the patient on ventilator. Now, whenever you make a thought that I need to put this patient on ventilator, the first thing which you will have to do is an endotracheal intubation, which we will see now. To intubate, you need to induce the patient. Induce can be done by many drugs. The most commonly used drugs are thiopentone, ketamine, propofol, etc. Now, please see, of these three, propofol is the most common and it is also used in sedation for this patient in ICU. Very common question. Okay, I hope that point is clear. Now, when you induce this patient, there will definitely be a fall in blood pressure. So that brings us to another question. Which all induction agents reduces blood pressure? An easy way to remember is all induction agent decrease blood pressure except ketamine. Ketamine is the only agent which actually increase the blood BP. I hope it is clear. Now, we just no need to induce, we should also paralyze this patient. So, paralysis is also important. There are various paralyzing agents. You can call them as depolarizing and non-depolarizing muscle relaxants. Of the depolarizing, choline is the most common. And non-depolarizing, you have many things like vecuronium, rocuronium, mivacurium, atracurium, etc. Of which the most commonly used one is vecuronium, which is considered as the most cardiac stable muscle relaxant. Now, any patient on ventilator need to be sedated. There are various agents which are used for sedation. The most common used, I already told you, is propofol. Second is benzodiazepines. Third is dexmedetomidine. It is essentially an alpha 2 is to alpha 1, selective alpha 2 is to alpha 1 agent, which can be given as an IV. It's a new drug. It's a probably a 3 year back AIMS question. So this is the initial part. Now we will see what all things we should learn before going to intubate. The MCQs associated with an endotracheal tube, the most commonly used tube nowadays is a PVC tube, polyvinyl chloride tube. For an adult male, we use 8 to 8.5 sized tube. The size is essentially an internal diameter. Okay. For an adult female, we use 7 to 7.5. Now, for a newborn, we use 2.5 to 3. In general, you can classify them into cuffed tubes and uncuffed tube. Cuffed tubes are used whenever the child is 8 years and more. Uncuffed tubes are, of course, when it is less than 8 years. Now, this is called the cuff, as all of you know, and this is the pilot balloon. A PVC endotracheal tube is a classical example of definitive airway. It's a very common question. Definitive means an airway which goes beyond the vocal cord and enter into the trachea. Endotracheal tube is an example of that. So it should have passed the vocal cord to call it as a definitive airway. Another example of a definitive airway is a tracheostomy tube. It's also a question. Okay. Now we will see what are the points which we should remember about when you want to put the patient or stabilize a patient with ventilator. The various variable. I'll brush through that so that when you sit in front of a ventilator next time, you will feel much more comfortable. You will be very happy. Okay. So to understand, we should understand 1, 2, 3, 4, 5, 6, 7 points. First one is tidal volume. Whenever you want to support a patient on ventilator, remember 5 to 6 ml per kg is the tidal volume which you should keep. Initially, it was considered to be 8 to 10. Now it has come down. Now, we don't inflate the lung too much, and we talk a lot about baby lung concept, which essentially means you don't inflate the cuff. I mean, you don't inflate the lung too much so that the lung will get barotrauma. You give only baby flows or baby inflation. Like instead of 10 ml per kg, we now give only 6 ml per kg. This is especially important whenever you are setting the ventilator for ARDS patient. Another question. Second point is about the respiratory rate. Normally, for an adult male, we keep it anything between 12 to 16. And when the patient has got COPD or asthma, you reduce the respiratory rate because you need a lot of time for expiration. Now, FiO2 we have already seen. Ventilator is an example of a ventilator is an example of a oxygen delivery device, fixed oxygen delivery device, where you can provide 100% oxygen. So we keep anything between 40% to 100%. The idea is saturation should be more than 93% at least with minimum FiO2. Okay. Now please see the next one. It is called PEEP. What is PEEP? It is positive end expiratory pressure. Positive end expiratory pressure is nothing but it is the pressure which is left over at the end of expiration. Because we know normally when you expire out, all the pressure should have gone down because the whole air is exhaled. Now, by applying PEEP, you always leave some amount of pressure within the thoracic cavity, within the lung, in order to prevent the closure of the alveoli. That is the point. So PEEP helps us to reduce the work of breathing so that next time you don't have to open because it is already kept open. Now, pressure support, it is nothing but the extra pressure which we are giving with the machine to the patient to reduce the work of breathing. Patient don't have to inspire too much because you are giving some amount of positive pressure. Now, what is IE ratio? It is nothing but the ratio of inspiration to expiration time. Normally, it is 1:2. That means you provide more time for expiration. Now, before leaving, you should always find out whether I have put my alarms on. Many times in practice, you would have seen in ICUs, alarms are constantly ringing and nobody look at it. So that should not happen. We should always keep the alarms on, set the limits, and attend to the call of the alarm. Okay, so these are the basic settings which you should look into any ventilator. Let it be the oldest of old ventilator and to the most modern ventilators. All the 7 steps have to be followed. Okay. Now, to understand a bit more about the modes of ventilation, which is probably the next one which you are going to keep, I'll just give you few terms. The terms are cycling, trigger, and limit. Now, what is cycling? Cycling is nothing but the end point of inspiration. Now, please see this. The patient is inspiring. At one moment, the expiration starts. This process is known as cycling. It is the end point of inspiration. So, depending upon the time. You can have ventilators which have got time cycling, volume cycling, or pressure cycling. Now, what does it mean? It's very easy. Please see, like, say, you start at 0 time. At the end of 2 seconds, you cycle. You stop inspiration and start expiration. Then it is called time cycle. Now, if this was volume cycle ventilator, you can put it in this way. Here, I'll kept it as 500 ml. So, in a volume cycled ventilator, the inspiration will stop when the lung get 500 ml of air, and expiration will start. This is called volume cycled ventilator. And third one is pressure cycle. Pressure cycle means so much of pressure is attained, then the expiration starts. So I can keep it at as 40, 35, etc., depending upon the clinical condition. So now you got the concept of cycling. Next is trigger. This is very important. What do you mean by trigger? Trigger only means that the initiation. The initiation. That means, just see this. Patient start breathing from here. This point is called the trigger. Initiation of a breath is called a trigger. Initiation is called trigger. So it can be either a patient can initiate, then it is called patient triggered, or a machine can trigger, then it is called machine triggered. So it can be possible in both ways. So whenever the patient is triggering, he depend he depending upon its clinical condition, he will trigger. He may inspire a bit amount of air, and then the ventilator will support. If it is a machine triggering, machine will trigger at a particular point. Say for example, in a 1 minute cycle, if we keep a 10 seconds as a triggering time, so at the end of every 10 seconds, a breath will be delivered. At the end of the next, so 10 seconds, 20 seconds, 30 seconds, 40 seconds, like that, 20 seconds, 30 seconds, 40 seconds, you will get a trigger. So this is called machine triggering. So machine trigger is mostly a time triggering, while a patient triggering is mostly a flow or a pressure trigger. So that is a general idea. Now coming to the third concept, which is known as limit. Now what do you mean by limit? Limit only means that the maximum amount of variable achieved. For example, I can keep a pressure or a flow as the limit, or even a time. That means once the inspiration start, the machine support until a particular pressure, say for example 40 centimeters of water is reached in the circuit. That is a maximum amount. So after, when it becomes 41, the expiration start, and there will not be a barotrauma. Same is this. If I keep it as 20 liters, with the patient, with the machine, you cannot get beyond 20 liters of flow. Okay, same as with the time. So limit is the maximum that this variable can get. Trigger is the initiation, and cycle is the changeover. That is how easily you can comprehend. Coming to the next point, which is called PEEP. PEEP is nothing but positive end expiratory pressure. Say, for example, this is inspiration, air comes in, expiration, air goes out. What happens? Next, it will collapse. The alveoli will collapse. For the next breath, you will have to put too much of effort to inflate the alveoli to the first stage. This is the work. Instead of this, if we apply some amount of PEEP, say for example, this is the first one. Once expiration starts, it comes down. But if you apply a PEEP, there will be a minimum amount of air left over to maintain a pressure in the alveoli. So the next time when you inflate, the work of breathing comes down. Work of breathing is reduced. This is positive end expiratory pressure, PEEP. PEEP actually reduces the work of breathing, improves oxygenation, and recruit more alveoli to take part in respiration. There are some disadvantages. It actually causes barotrauma if exceed more than the physiological value. Say, for example, more than 15 centimeters of water. It is useful especially in acute low compliance status. But at the same time, hello? Yeah. At the same time, it may have some deleterious effect in patients with emphysema, asthma, or other asymmetrical condition because it can open up those alveoli which are already open too much, while the other alveoli is left behind, and asymmetrical expansion happens and can again result in barotrauma. Very common question about the side effect of PEEP is that it reduces the blood pressure, it reduces the urine output, it reduces the mesenteric blood flow, but it increases the ICP. Very common question. Now, various modes of ventilator. I'll just give you a rough idea about various modes. Please see this. What is CPAP? CPAP is nothing but pressure support to a spontaneously breathing patient. I'll put it in this way. This is a patient breathing normally, normal, spontaneous breathing. Now, if I apply a CPAP, we are actually providing pressure support to this. So what happens? The tidal volume increases. Okay, that's advantage. So CPAP is nothing but applying pressure support for a spontaneously breathing patient so that increase in tidal volume, decrease in work of breathing happens. Now, what is BiPAP? BiPAP is very simple. It applies pressure during inspiration as well as during expiration. During inspiration is called IPAP, and this is EPAP. Both are important to reduce the work of breathing. Now, we will see the other ones. Controlled mandatory ventilation. This is probably the first ventilatory mode, first mode that you put any patient when he's totally paralyzed. Or another common question, when he has got a head injury, because he don't have the trigger to breathe. The definition is that here patient has no role. Patient has no role. It is essentially the machine which breathe for the patient. In fact, I can say the machine triggers, the machine limits, and machine cycles. Now, what is IMV or intermittent mandatory ventilation? So, if I represent control mandatory ventilation, it will be something like this. At fixed intervals, the machine keep on giving symmetrical breaths. Now, what is IMV? Here, the patient gradually start breathing. So, in between the mandatory breaths which the machine gives, the patient also breathe a small. You can see small breath. This is patient effort, and this is machine's breath. This is called IMV, intermittent mandatory ventilation. That means in between, whenever the patient is breathing, we give mandatory breaths. Mandatory means compulsory, which is given by the machine. Next comes the most popular mode, which is known as SIMV. What is SIMV? SIMV simply means it is more physiological one. In fact, there are few breaths which are mandatory given by the machine. Along with that, these small patient breath will be augmented by the machine. So small patient's breath will be augmented. So this is most physiological. Okay. So this is called SIMV, synchronized intermittent mandatory ventilation. There are few mandatory breaths, and there are few synchronized breaths. Few synchronized breaths. So this is essentially SIMV. Okay. Next. Process of weaning. Weaning is nothing but gradually taking off the patient from the ventilator. This is a very complex, I could say, or very scientific method of doing. First, to start with, you put the patient on CMV, we have already seen. Then you put the patient on SIMV. Then you just give some pressure support or CPAP or BiPAP, and then get the patient onto TPs and then off the ventilator. This is probably one of the most commonly or popularly used way. Of which, another question which is commonly asked is, what is rapid shallow breathing index, RSBY? It is nothing but the respiratory rate divided by the tidal volume. If you get less than 100, or you can say 105, you can think about extubation. And if you get more than 105, you shouldn't think of extubation very easily, because there is a chance of weaning failure. So rapid shallow breathing index and various modes of weaning are also important. To give it in a nutshell, I would say SIMV, pressure support, TPs, BiPAP are all weaning modes. Are all weaning modes. While control mandatory ventilation is not a weaning mode. That's a very commonly asked question. Now, what is NIV? NIV is a common principle which has come up, which is used especially in COPD patients or patients with OSA, where you don't intubate, but you give them positive pressure through a mask, which is kept tightly onto patient's face. So he can breathe in through that and exhale into that. Okay, this is NIV. In non-invasive ventilation, there are few points to remember. One, patient should be awake. That's a very common question. There should be a Riles tube in situ, because to prevent the stomach from getting inflated, he should never be sedated. So head injury, NIV is a contraindication. That is a question. We have few chat. Oh, what is TPs? I'm sorry, I thought you know that. Okay, I'll come back there. This is the TPs. Now TPs is nothing. It is like this. A small tube which will be attached to the endotracheal tube. Of one end, you give oxygen flow. So oxygen will give through one end, endotracheal tube at the other end, and the oxygen which is coming from the oxygen flow will go into the patient. Patient will expire, and expired gas will be exhaled to the open side. After removal of TPs, you can extubate the patient. The maximum time of TPs trial is 20 to 30 minutes. That means you can put a patient on TPs only to a maximum of 30 minutes. That's it. Okay. I hope that is clear. So with the NIV, I think we should think of stopping ventilation. Okay. Thank you. If you have any queries, you can get back to me. Either you can mail to Dr. Swapna, I'll answer it, or you can connect on my Insta. We'll be happy to answer. I hope it would have been useful. And I'm sorry I get a lot of echo and it's quite disturbing, but unfortunately, maybe there is a network issue happening. Yeah, there was few queries. I'll answer those queries. What is a contraindication for NIV? Okay, the absolute contraindication for NIV is a patient who is not conscious. Patient not conscious. Number two, if there is a fracture on the nasal, bar maxillary areas, or there is a bleeding. The commonest MCQ is head injury, patient with head injury. Number four is full stomach patient, full stomach patient. Okay. Now the next question is from Dr. Sajin, volume control and pressure control. Okay, it's very simple. Volume control, pressure control. Now see the word control. Okay, the word control is, it is the one which we can keep as a maximum. Say for in a volume control, 500 ml, you consider as 500 ml as a volume control which you have kept. Our target is to achieve a 500 ml of tidal volume primarily for the patient. Now, number two, if it is a pressure control and we keep a pressure of around 35 to 40, our target is to achieve this much of pressure in the circuit. So we have no guarantee on the tidal volume, because we are only looking at the pressure control. Suppose a lung is poor compliant, the pressure control may stop bit early without delivering the adequate tidal volume, while volume control will definitely give that much amount of tidal volume. Essentially, in practical ways, volume control we use it for adults and pressure control we use it in pediatrics to prevent barotrauma. I hope that is clear. Now, what is the next question? NIV Riles tube a must? Yeah, that's a good question. Theoretically, NIV we should keep a Riles tube. Why? Because in NIV we are actually flowing air in a very high pressure into the nasal as well as oral cavity. So there is a very chance that the patient will open the mouth. Patient will open the mouth and engulf some amount of air also. So that air, if it goes inside, it will splint the diaphragm and will not be able to breathe better. So you put a Riles tube to deflate the stomach. But if the patient is confident and they don't engulf a much, they are come to that level, you can remove a Riles tube and see. But theoretically speaking, NIV is best worked with a Riles tube in situ. Okay. Why Venturi mask has some different colors and why does it indicate? Dr. Roshni, please, if you look into the slide, I'll show you. Yeah, this is a slide. See, if you look carefully, I'm not sure how much is evident from that side. But see, on every mask, there is a particular percentage of FiO2 written over there. That means if I want the patient to get 60% of FiO2, I'll keep that colored mask. 40%, 44%, depending upon what is the FiO2, I keep that color mask there. So that will be the aperture size. That will allow the speed to that level to entrail that much of FiO2. That is why we have different colors. Color coding of FiO2 has not been asked in any of the FMGE or AIMS questions or INICT exams. They have asked only one question about Venturi, that what is the maximum FiO2, that is 60%, and also they have gone what type. It is fixed performance device. What is the normal minimum PEEP value we should keep? Okay. The minimum PEEP, what you need to keep for a patient on endotracheal tube is 5. 3 to 5 is the range given. 5 is the minimum as far as entrance question is concerned. No, color coding we shouldn't, because till now there was no question asked on color coding of Venturi. HFNC and CPAP. Dr. Ambli. Okay, HFNC is very simple. High flow nasal cannula. I think I have shown you the diagram. This is HFNC. It is otherwise called high flow nasal oxygen or high flow, which is delivered through a high flow nasal cannula, which is a definitive device, definitive oxygen delivery device. While CPAP is continuous positive airway pressure, which is applied by a CPAP machine, most commonly used in OSA. We have already mentioned regarding patients who are weaning off from the ventilator. Now, in both, the patient is better with some amount of pressure support. The advantage is HFNC provides a very high flow, like 70 liters, while CPAP doesn't give that much of amount. Okay, so that is essential difference. I hope the point is clear.